So just to sort of set up the panelists a little bit before I introduce Angelo. Wow, I wish my health and mental health policy course was so quiet. Just kidding. A number of them are here. So I'm going to give you a little word salad. So hopefully by the end of this, so this is the future sooner than you think, because it's here now, as Charlie sort of suggested. So this is all the various terms. Don't stare at it or anything. But hopefully by the end of the panel conversation, some of this will start to make a little bit more sense to folks. So here are all the various kinds of things that sort of surround a patient experience. The blue should be care coordination. That green thing, that sort of eggy looking thing, is sort of what we're calling these days population health management. And the glue to all of this, to the patient experience, is this: social work. And hopefully, once I introduce Angelo and this incredible group of panelists who are social work boots on the ground, that word salad will start to make some sense. And I think as Charlie sort of set up the challenge, I think, in a lot of what I think Angelo and the panelists are going to talk about, and that is the role of social work as care coordinators, as integrating behavioral and physical health care, and their roles defined, the opportunities, the challenges in this wonderful new day. So it is a great honor as we start this next part of the panel, and there will be Q&As, so please hold some of your questions, hopefully, for the panelists and for Angelo. But a friendly reminder for all of those of you who want CEUs to please go out and get the evaluation that you have to hand back in order to get your CEUs. But as many of you know, Angelo is well known to Massachusetts and the Boston College School social work community. I will not reiterate his distinguished biography, but simply say we should all be very proud to have him as the national face of the social work community in his still new role as president and CEO of the National Association of Social Workers. Angelo and I have long, wonderful history together. I consider him a friend, someone who has dedicated most of his professional experience to the public sector, whether it's within the Commonwealth of Massachusetts, in New Jersey, or in fact when he worked at the Mass Behavioral Health Partnership, and many years ago as a young social worker in the Department of Mental Health. So many of us in this room can say we knew Angelo when, but it's a true, true honor to welcome him back to Boston College and to moderate this great panel. So Angelo, please join us.
Hello, everybody. You guys energized? Okay, we're good. Well, it's not important if I'm energized or not. No, one of the first times I met Mary Lou, I was working when I was a young social worker. She said to me, "Don't screw this up." And so I remember that because Mary Lou always is a person who sought for the highest of quality. And when she said it to me, I said, hello to you too. And I didn't think we'd ever be friends on that particular day, but we've been very good friends, and we've had the pleasure of working across many different domains, whether it's trying to improve the mental health system, trying to improve the child welfare system, or trying to improve our health systems. And it's really exciting to me to be here in Massachusetts. Many of you may think I've moved to Washington, D.C. Actually, I'm still a Massachusetts taxpayer. And Charlie Baker is not governor yet, and he's not left the room, but if he were governor, he would be appreciative of the fact that I'm still a Massachusetts taxpayer and plan on being a taxpayer here for a while. It's really exciting to see so many people who are interested in social work and interested in health care and how those two come together. And we're going to have, as our panel, you hear from our panel, the health reform, the Affordable Care Act. It's such a golden opportunity for social work. And we've got our historic education frameworks and models have prepared us well to be able to move forward. I'm going to share a few of my thoughts, and then I'll introduce the panel. And as I've been in this role as the Chief Executive Officer of the National Association of Social Workers, and it's really a privilege to, it was an honor and a privilege to serve as Commissioner of Child Welfare in Massachusetts for 6 years. And as I've traveled around the country, you may not feel it now with all the stuff that's going on in the media here locally. As I travel around the country, and I mentioned the fact that I'm from Massachusetts and worked in child welfare here, people immediately want to get my ear and get my attention to talk about the reforms that we got here, the way we got the outcomes. And there are many things that we take for granted here that other parts of the country envy us on. I actually had the privilege to be in a congressional briefing up on Capitol Hill several months ago and talking about the intersection of poverty and child welfare. And we had academics, researchers, and advocates talking, but we only had one person who actually had run a state system who actually talked about what it looked and felt like on the ground. And people were really impressed with the stuff that were going on here. And it's a privilege for me to talk about these things as I travel the country, because it's the whole community that has made these things happen. It wasn't myself, it wasn't the agency, it was the whole community, from the medical system, the school systems, the courts, law enforcement, the provider community, the advocates. It was everybody pitching in, and making that change. And as you think about your child welfare system here now and the challenges you're facing, it's really the whole community coming together that's going to make that difference. And as I've been in this role and going across the country, and actually I was in St. Louis, and I saw Alberto, our dean here, and he says, "What are you doing here?" So I'm traveling the country to find out what's going on in social work. This social work, for those of you who are social workers, I want to ask you to raise your hands, because probably all the hands will go up in the room. I saw one hand go up. You have chosen a really cool profession to be in. Our profession is so broad and so deep. There are people doing so many things. I found out the other day that Wendy Sherman, who is a social worker, a former child welfare commissioner, she has been leading the negotiations around limiting Iran getting nuclear weapons. So we've got social workers doing all kinds of things, and she's using those social work skills. When I talk to social workers in Congress, I talk to Krista Sinema, who's almost a Republican. She's a Democrat from Arizona, and she says, all she hires in her constituent office are social workers, because constituent work is social work. It's just good old-fashioned casework. I've had the privilege of serving on a national palliative care advisory committee. And when I talk to the doctors and nurses and pharmacists in the palliative care world, and if you think about palliative care, if you think about the 80 million baby boomers who over the next 35 years are going to be in that category of needing, assistance with long-term care, and you think about palliative care, and one thing I'm learning, that palliative care is not just end-of-life care. Palliative care could for anyone who has serious or chronic conditions. But my palliative care colleagues now, because I've been on that national board, when they talk about the role of social work and they articulate the importance of social work on the teams, they say it in a way that social workers, we'd have a hard time struggling to say it. They say we could not have effective palliative care if we didn't have social workers on the team. They talk about what you guys bring to the table. They say we are trying to pick up the skills you guys already have. You guys already have the empathy. You start with empathy. We have to have a checklist to remember to say, okay, let's make sure that we are empathetic. You guys understand the person in the environment and the holistic care. We have to kind of try to get there. You understand about working in the community and providing community service. You understand about transitions. 10 years ago, I used to always think of transitions as discharge planning, aftercare planning, but more and more in health, we're going to be hearing about health transitions. And hear the docs talking about social workers understand health transitions. So we have skill sets and approaches to doing things that the other professions really envy and are looking forward to us to trying to catch up. And actually, they say we're trying to play catch up. And one of the things they also said to me, which was kind of interesting, they said, you know, we have social workers on our team, and said invariably the social workers, and this is, I'm about to throw a challenge down for you guys, our social workers, they seem to devalue themselves, they seem to need validation, they seem to not understand the value and the impact and the power they bring to the table. And so as a profession, we have to understand the power we bring. We have to understand who we are. You know, if you look back across the last the 20th century, and many of the major positive things that impacted social welfare for our country, there was a social worker lurking in there. You know, I know you guys know Francis Perkins. You know, if someone's getting a Social Security check, you can thank a social worker. If someone's getting benefits from EAP services, you can thank a social worker. You know, Dale Massey, who was from Massachusetts. I could go on and on about what social work has brought to improve social welfare in our country. So this is a challenge to you guys, and some of the panelists are going to talk about how do we earn our value at the table. You know, how do we, bring that there? But we should all be saying, look, I'm part of a profession that has brought so much good to this country. I'm part of a profession that when the country thinks about investing in social welfare, investing in positive social welfare, one of the best investments the country can make is investment in social work. And that's part of my message I've been taking across the country. New Mexico, Nevada, Louisiana, that I've been in just in the last couple of weeks. I'm going to Minnesota, South Dakota, many other places to really bring that message about the value that social work brings. And it's really exciting for me. I've been going around and hearing all these cool things that social workers do. And much of this work they do is in obscurity. You know, no spotlight, no limelight. And so I give you that challenge. And Charlie D. Baker Jr., he talked about the two most important numbers in healthcare, 5 and 50. And he shared with us that he thinks there's two populations. And, you know, that 5% of the users eat up 50% of the cost. And that's a place where social work can come in. We can help change that number, where we can help be more proactive and more aggressive treatment for that 5%. So we can take the resource and spread it out so more folks can get more of the care they need. So the skills we bring, if you think about integrated models, if you think about the Affordable Care Act and the opportunities for social work, I mean, some of them are obviously, you know, patient navigation, care coordination, you know, behavioral health treatment. You know, as I go around the country, I talk about one of the things we saw here in Massachusetts, where more people had the coverage where they could get their behavioral health coverage. And then there's roles for social work in terms of the accountable care organizations and managing and directing those organizations. But if you think about it, integrated models and interdisciplinary will be what's going to drive. And we're going to have to have really good teams, because healthcare's focus is going to be on keeping people healthy, keeping people at home, keeping people in the community. And payment structures are going to be such, which will be really fun and cool to get those payment structures in place. But rather than getting paid for episodes of care, getting paid for keeping people healthy, the social worker is going to be right there front and center, being able to bring our skills. If you think about the skills we have in terms of understanding the social context that people live in, understanding the relationships that people have with each other, understanding how the social contact that they live in impacts their health behavior, the way they think about health, their health outcomes. If you think about what we bring to the table in terms of our systems understanding, and our systems understanding is going to be so critical. because someone's going to have to connect the dots. Someone's going to have to bring about all those linkages. Someone's going to have to make sure as the patient goes back into the community goes back home, that all of those things, those instructions, those discharge, those transition instructions, that there are resources to follow up on them, and that there's the kind of health behaviors that are going to follow those. When you think about our ability to take research and understand, research, in terms of person and environment, and understanding the interactions between behavioral health and physical health, and how those interactions impede or enhance a person's health-seeking behaviors or their impact. Sometimes a person might, there may be an issue with diabetes, and to say, well, really, what's impacting the good care there could be depression, or there could be an issue with a person not sort of following through with their medications. Maybe the issue is transportation. So the things that we bring are going to be the kind of skills that are going to be needed as we move forward with advancing healthcare and making sure people have optimal health. I'm going to sort of segue now and introduce our panel. And we actually had a terrific discussion last Monday, and talking. We were talking about how we would want to give you a larger systems perspective, and give you a perspective from a teamwork perspective, and then give you a perspective from a community-based perspective. We have Carol Kress here. Carol is a Chief Operating Officer from the Massachusetts Department of Behavioral Health. She's got responsibility for all the overall operations within Massachusetts Behavioral Health, and she has been there for many years, I'll say 15. So I was actually part of the crew that hired Carol, and we were intentional saying we need someone who's got really good people skills, someone who can be flexible and who can sort of work in the ambiguous kinds of situations, because she's dealing with, just listen to this list: quality management, utilization management, network management, reporting, IT systems, claims, human resources, contract compliance. She has all these pieces sort of coming together to make sure she's putting those links together. Before she worked at MBHP, she was a community clinical social worker, and she's got an MSW, and she's a licensed clinical social worker. We've got Mary Neagle, who's from Partners Healthcare in Massachusetts General Hospital. Mary has an interest and expertise in health promotion, disease prevention, and quality improvement. She's been at Partners since the late 1990s. She has a master's degree, and guess where she's from? And a master's degree right here at Boston College. We also have Rebecca Osario. Rebecca is an MSW and a licensed clinical social worker. Guess where Rebecca's from. She served as a clinical social worker. She graduated from here in 2008. And she's part of a clinical team that looks at integrated care and how to make those links. And actually, Rebecca and Mary are going to, part of their presentation will be a demonstration of teamwork. And also, part of their presentation will be, how does the macro and the micro, how does that fit together? Let me just see a show of hands how many macro social workers we have in the room. Wow. Ooh. I ask that question a lot as I go around the country, and oftentimes I don't see any hands, or I see 2 or 3. And I was actually in Nevada and was meeting with a group of people, and there was one person who was a macro social worker. And when I told her I've been sort of really encouraging folks to consider the macro tracks, and because eventually all of us, we do macro work. even if we're at the micro level, at some point in time in our career, we bump into an issue that says, hey, I got to take a macro approach to solving this. So I'm like, wow, there's a lot of hands that went up in the room. And then we have with us Scott Turton. He's an MSW and an ICSW. Interesting about him, he got his degree in Canada. And I was actually in New Mexico earlier this week, and one of the presenters was from Canada. And he talked about working in the Yukon, and it's probably 3,000 miles north. It's way up there. But Scott works at Gosnold. He's the director of their primary care integration program. He works with primary care integration and with electronic medical records. And he works to make sure that behavioral health and primary care are integrated. And so this is our group of panelists. I think what we're going to hear from them, and I'll just kind of review this list so you guys can hit on these points. I can get to my notes. They're going to share with you the skills and the values that social work brings that are important to healthcare. They're going to talk about the opportunities and challenges and how our skill sets can help us address those opportunities and challenges. They're going to really stress the importance of patient-centered care. They're going to talk about the macro perspective in social work and how the macro perspective is going to be important as we move forward. They're going to share with you some thoughts about the social determinants of health and how, as we can better articulate those social determinants of health, how that can help us with payers. You know, payers are interested in the bottom line, and so we need to be able to articulate how addressing those social determinants can help with the bottom line. We'll talk about that. They're going to talk about the importance of interdisciplinary teams and the importance of having a holistic approach. And they're also going to talk about how do we earn our seat at the table and what are things that we need to do as social workers to be able to earn our seat at the table. So with that, I'm going to turn it over to Carol.
Thank you, Angelo. Good afternoon. It's a pleasure to be here. Can you hear me okay? Okay. It's a pleasure to be here. I appreciated Charlie Baker's comments about Mass Behavioral Health Partnership back in the 90s, and his vision is something that we are grateful for, and glad and very proud to be part of the healthcare delivery system in Massachusetts for all these years. I also see Michael Norton in the audience, who also led some of the thinking early on for a behavioral health company in Massachusetts and how to continue to improve quality, access, and the experience that our members have. So very happy to be here. I'm going to start by talking a little bit about who MBHP is. We're contracted with Mass Health and Health New England, which is a Western Mass health plan, to manage care for about 370,000 Mass Health members. We have 5 locations across the state and 250 employees. 28 of those employees are social workers, and they're in a variety of roles at MBHP, from integrated care managers. They're social workers in our quality department who work with providers talking about the data, the utilization, the access issues. And I thought you'd be interested to know that we also have our Director of Information Technology as a social worker, and our Director of Communications, a BC social work grad who's here now today, is also a social worker. So there's a breadth of roles for social workers out there in the current environment. We have a network contract and credential over 1,200 clinics, group practices that are inpatient, outpatient, emergency, and other behavioral health services. And those network of providers serve over 120,000 members annually. We also work with, in the spirit of integration, 380 primary care practices. For those primary care practices, as well as our behavioral health providers, we take a look at the medical, behavioral health, and pharmacy claims data and bring their data out to them and discuss what their data looks like with them, what are some quality improvement activities we can work on together, are there barriers or access issues that is identified through the data that we can work on together. How do we do it? So we manage utilization by focusing on quality. We promote diversionary and community-based care. We provide integrated person-centered care management. And some of the things that we do in particular around integration activities, and again, they're at the systems level, they're at the provider level, and they're at the member level, but we train primary care clinicians in depression, ADHD, substance use disorders, and serious mental illness. We work hard to link behavioral health practitioners and PCCs through consultation referral. And we also really strongly want to emphasize the role of recovery, resiliency, and peer support. And one of the things that was striking in the previous conversation today is really wanting to make sure that in the teams that we're talking about, in the service delivery system that we're talking about, that our consumers have a voice and are empowered to be part of that team and articulate what they feel they need. We use data and technology to drive improvement, and we focus on performance measurement and quality outcomes. And I'd like to give a couple of examples of some of the integration activities we do. This is a systems level one. Many of you may have heard of the Massachusetts Child Psychiatry Access Project. It was developed a number of years ago in collaboration with DMH and Mass Health to design a system of regional children's mental health consultation teams to help primary care providers meet the needs of children with psychiatric issues. So I think it's important to note that this program is run by a social worker and a pediatrician who work closely together. And each of the consultation teams, there's one in each region, has a social worker on the team. And it's really a way to integrate and support primary care practice docs, pediatricians, in serving the needs of children with mental health issues. Less complex needs may be able to be served at the primary care office, and more complex needs can be triaged to child psychiatrists. So it's worked out very well here in Massachusetts. Over 98% of Massachusetts children are covered. And since the inception of this program, similar programs have been implemented in 24 states. Another example of some of the work that MBHP is doing, this is at the member level. We've designed an integrated care management program that has a strong emphasis on both behavioral health and medical conditions. It's designed to improve the overall health outcomes of members, and it's built to serve over 5,000 individuals. We use a predictive modeling tool, algorithms that take a look at behavioral health, medical, and pharmacy claims. We want to be able to target those individuals who have the highest need, the most complex need, and make sure we're reaching out to them and finding them. Some of the conditions that are part of the algorithm, again, it's a blend of medical and behavioral health, such as asthma, bipolar illness, COPD, depression, diabetes, substance use, schizophrenia, coronary artery disease. So it's a combination of medical and behavioral health condition management. We have care management teams across the state, and this program is run by a social worker, an internist, and a nurse, and the actual integrated care managers are a combination of social workers and nurses. We do really want to focus on, what are the outcomes, what is the data telling us, and so we've designed 4 outcome measures that we're tracking over time. We'd like to see a reduction in polypsychopharmacology, reduction in preventable hospitalizations, improved enrollee health-related quality of life, and member satisfaction. The program is just about a year old now. We're just starting to get some information in about these various measures. So we've touched on this. Previous speakers have touched on this. I think, we really want to emphasize social work values and skills that really cover the breadth of all of our roles. I've worked at MBHP for over 15 years now in a variety of roles. And I have to say that not a day goes by where I'm not using the social work skills that I learned in social work school or the social work values that I embraced as part of my training experience. And it's just amazing. Every single day, those skills I'm using. And I think these are just some skills to highlight, or values to highlight, as we go through this systems transformation, some of which has been touched on before. I think social workers are great at thinking of holistically, valuing consumer voice and self-determination, cultural competency. I think social workers uniquely recognize the value of relationships and listening skills. Let's listen to what our clients are saying, what the system is saying, what providers are saying. At MBHP, we have a number of advisory councils. We have a consumer advisory council, a family advisory council, and a provider advisory council. And I can't say enough about how valuable their thoughts and ideas, what's working, what's not working, has been very helpful. Resiliency and hope, I think, is a value of social workers, a strength-based approach, and understanding the person and the environment. With regards to the future of where things are evolving, I think some of these skills, and some of them have been touched on already, are needed for our work going forward in order for integration to be successful. I think there'll be an increased focus on preventative health and wellness. I think social workers will need to be familiar and competent with both medical and behavioral health terminology as we integrate our teams of staff. And Charlie mentioned this. I do think growing comfort with data, it seems to be, it'll be bumpy at first because there's so much data out there, and what's the right kind of data and how to use it. But it's going to be an incredibly valuable way to show how things are going in this transformation, how, what's working well, what's not working well. I think social workers making sure they have a knowledge of a variety of care delivery systems and payment models, such as health homes and bundled payments. Health homes, I think, are critical, and I would say we should think a little outside the box in support of some of the advocate for behavioral health homes. Most of the health homes are in the primary care practice, which is great, but because there's a percentage of our clients who feel more comfortable sometimes in a community mental health setting, to have a behavioral health home and the medical there, I think, is a valuable thing to advocate for. There'll be a continued emphasis on evidence-based practices and outcomes, and again, the health care systems navigation is crucial. Charlie mentioned it, and I just think the more that we can familiarize ourselves with the joint terminology and all of the language of this transformation, it will only help better serve our members. So I'm going to pause here, and I'm going to now turn it over to Mary and Rebecca. Thank you. Do you want the doohickey there?
Thank you. Good afternoon. Thank you so much. My name's Mary Neagle. I'm a 1985 graduate of what was then the Community Organization Social Planning Macro Program. So I know in the program it says I'm an LICSW. I'm really not. I I knew right away, I knew immediately that that was not the track for me. I would bring everybody home for dinner. And I would house them, and I would burn out. And I am very grateful and learned very early to be grateful for the work of colleagues like Rebecca Osario, clinical social worker at the Integrated Care Management Program at Mass General, and the work that they do. I am humbled every day when I hear about the work that our team does. And I think of myself with a master's in social work as actually being an agent of theirs and being of service to them and the work that they do in patient care every day. So what I wanted to do is tell you a little bit about the Integrated Care Management Program to give you some context. And then Rebecca's going to talk about her role as clinical social worker on our team. And then I'll talk a little bit about my role as project manager and the training that I received here as the backdrop for my work professionally at Mass General for the past 15 years. And in healthcare for 30 years. Absolutely amazing to think that it's been that long that I've been working in healthcare. So let me just start by talking about the Integrated Care Management Program. I think Charlie Baker just laid the groundwork for us beautifully. This is all about the work that we're doing, and the work you're going to hear about today is about transforming care. It's about acknowledging that not all patients are alike, and if we treat patients the same, they're going to fail. We work with high-risk medically complex patients in the Integrated Care Management Program. And what drives the work we're doing? We began in 2006, and sad but true, and a lesson learned for me early on is what often drives change is the dollar, the budget. So I would say one of the things that was very important for me to learn here is how to read a budget, how to create a budget. Very, very important. So we've made tremendous headway in this country in reducing the cost of care. You'll see the difference from left to right. The cost per capita for Medicare back in 2010 to 2000 to 2011 was 6.9%, and it's down per capita to 6.3 when we look at 2012. And what's projected to 2021. We are making headway in reducing the cost of care per person, but what's important to note is as a percentage of the gross domestic product. We're not making any headway there. We were at 2.8, and it's anticipated to rise to 4.1. And this has been the force behind a lot of the change. It's, you hear it all the time. The 20% can consume 80%, the Medicare patients who are bankrupting the Medicare Trust Fund, and on and on and on. If we continue to do business as usual in healthcare, not only will our patients fail, but we will fail as a healthcare system in this country and in Massachusetts. So what we've found is that in fact, you can't treat all patients alike because not all patients are alike. And you need, in order to be effective in healthcare, you need to meet patients where they're at, not where we're at as healthcare providers, which historically has been the model. Healthcare providers drive the model, and we expect patients to conform to our structure. And in fact, what we've learned with the coming of age of the baby boomers is that we need to be prepared and to meet them where they're at. So this is what we call the funnel of bad outcomes. So if you think about the arcade and you put the penny in and it starts to spin. So if you think about this funnel, at the top of the funnel, it's very wide open. That's really population health management. That's the general population. And as you walk your way down that funnel and it gains speed, as does our patients, you move from healthy patients to those with chronic illness, maybe diabetes, maybe hypertension, to the patients that we're working with now in the Integrated Care Management Program, the medically complex, the high utilizers, so the patients with 2, 3, 4, 5, 6 comorbidities. They're on 10 plus medications. And what we find is that the intervention that you have to provide these patients is far more specific and has to be customized to meet their needs. So we think that in healthcare, as Charlie mentioned earlier, the greatest opportunity is working with the high utilizers. If in fact you want to make a difference in the rising cost of healthcare. So this is the population that we've focused on at Mass General. This looks a little fuzzy, but this is what our patients really look like. Now, this is a patient that came in to see one of our pharmacists, and instead of a brown bag pharmacy day, it was a brown suitcase. Imagine this patient's experience with healthcare: multiple comorbidities, multiple medications, the ability to navigate this table of medications is not possible. It's not possible for me, and it's certainly not possible for a patient with multiple comorbidities, and maybe as they age, issues with cognitive functioning as well. What we find with the patients that we work with, and it's the reason that's really drawn us to social workers as an integral part of our program, is that 41% of our current population have a psychosocial, I call it a psychosocial overlay. And it's really, there's a continuum from those patients who have episodic depression, maybe due to loss of a loved one that they've lived with and been married to for years, to patients who have long-term chronic psychiatric illnesses and everything in between. And as Angelo mentioned earlier, if you're not addressing the mental health issues of your patients, if you're not addressing the patient as a whole, your ability to support that patient issues of diabetes, of hypertension, of any of their medical issues are significantly reduced. You will be unable to be effective with that patient if you have not addressed them as a whole person. So this data has been very important to us. It's data that we look at regularly to get a sense of the needs of our patients. What we've done with the Integrated Care Management Program is developed a model building on the medical home concept. We've built a model that has the patient at the center with their primary care physician and a nurse care manager supporting them. And then surrounding them are other specialties that we think are vital to successful outcomes for our patients. And that includes clinical social workers, community resource specialists, and pharmacists. So the term that may be not as familiar to folks as the community resource specialist are those folks on our team who are all knowing about state, federally, locally, and privately funded programs. What we ask our team to do is work together as a unit to support the patient. We think of the work that we do as kind of mass customization. We have a set of tools in our toolbox, and depending on the patient and the patient's needs, we take those tools out. So the nurse care manager, after completing a comprehensive assessment, medical assessments look at medical issues. They don't often look at ADLs and IADLs and fall risk assessments and markers for mental health issues. When our nurse care managers assess our patients, they look for the markers of mental health, and then they'll refer to our clinical social workers. While our nurse care managers are well trained in medical issues, they're also trained to identify mental health markers, but they're not trained to treat mental health issues. And that is really the domain of the clinical social workers on our team. So the team works together, and they're available to support the patient as a group. Our program's been in existence since 2006. We started as a Medicare demonstration program. And as a result of years of work now, we found that we've had both qualitative and patient satisfaction. And this is, for us, is our triple aim. We really look to see that our physicians are satisfied, that our patients are satisfied, that for our team there's a work-life balance, that there's a feeling and a sense of satisfaction in the work that they're doing. Similarly, we looked to see that there were clinical outcomes for our program, and this included over the course of the first 3 years of the program, there was a 20% reduction in inpatient admissions for our program, for our patients, a 13% reduction in emergency room visits, and we're really thrilled to say that over the course of our program, our patients live longer. So they lived longer, and these clinical indicators for us, these outcomes are an indicator of what we think is a better quality of life for our patients. And then finally, there was savings. Our program at the end of the day, it was a Medicare demonstration program, had significant savings. There was a 7% savings. There was a 12.1% gross savings and a 7% net savings for the program. And for Medicare, as part of this demonstration, for every dollar they invested in the program, they saved $2.65. So a return on investment that was significant. For us, this is the triple aim. And for us, it's really the sweet spot in the center, that in order to be successful in the work we do, there has to be improved health, there has to be savings, and there has to be an improved experience for the patient and their providers. And that's our triple aim, and what we've sought to achieve as part of a multidisciplinary team. I think this, though, really says it all. So this was the patient before we began working with them. And this is the patient today. And that's what their meds look like today. It's not rocket science, the work that we're doing. It's really meeting the patient where they're at. It's acknowledging the fact that the patient is not a medical illness, but a whole person. And it's providing the patients with the resources they need to eliminate the barriers to good outcomes. So with that, one of the most important tools in our toolkit is Rebecca Osario, one of our clinical social workers. So I'm going to just pass this on to Rebecca to talk about the work that she does.
Thanks for the backdrop. And I just want to give you a sense of what it's like to work with that small percentage at the top, that highly complex population on a day-to-day basis. It's not traditional social work in the sense of sitting down doing therapy with a patient, what you really think about when you go to social work school. With our patients, it's really a sense of making an individualized plan and doing what needs to be done and meeting that patient where he or she is at. Like Mary said, we have an embedded care management model. So we have nurse case managers who are situated in the different primary care offices. And then they utilize us as resources to work with patients over time along the continuum. And as we were talking about teamwork before, we were thinking about how roles need to be delegated. And that is one of the primary focuses of our program, that everyone in the program is working at the top of their license. So like Mary said, our nurse care managers are not spending all of their time dealing with the psychosocial issues of our patients. So that's when they utilize us, and when patients are taking up way too much of their time and they're not able to use the skills that they have as nurses to improve the health outcomes of those patients. So that's where we step in. And at that point, it can be patients with classic mental health issues, substance abuse issues, can be psychosocial stressors, adjustment to illness, caregiving, end of life, palliative care, financial stressors, which the stressors vary based on the payer that we're working with. We are now working with a variety of payers, not just Medicare, so the population can look different and the stressors can be different, which keeps us all varied in terms of our skill set, which is a good thing. We can have isolated patients. We have patients who end up in the emergency room because they're lonely or because they want cranberry juice. Situations that we can come up with creative solutions to try and figure out in what way we might be able to step in there. Patients that don't fit the traditional mental health mold, they wouldn't be able to go and meet with a therapist weekly and keep their appointments. They wouldn't like the idea of a social worker or a therapist or a psychiatrist being in their business. Those are the kind of patients that we can slowly work to engage So when we do receive a referral, sometimes it can be for a consult. You know, the care manager's just trying to figure out what's going on there. They need another pair of eyes to look at this complex patient. What might we be able to do differently here? And then often it's to do an assessment of the patient and then to work towards engaging that patient, which is an ongoing process. It may take years. We've had patients that, you know, I've worked with for years before they've agreed to come in and meet with me or meet with the psychiatrist. And they would only do that then when I would accompany them to the psychiatry appointment. We would meet with them together. Or meet with them with their PCP, someone that they trust, so they would get to trust me and know to work with me. So those are some ideas of how our interventions work. Sometimes we do a lot of triage, referrals out to community agencies, to our MGH psychiatry or social work department, if that's the way that that patient would receive care. Otherwise, we could do face-to-face meetings with patients, phone work, family meetings, joint meetings with other members of the team, specialists. I've accompanied patients to appointments at the cancer center. I've accompanied patients to support groups to help them get situated there. Inpatient visits in coordination with the inpatient team in order to help bridge that gap between what the patient is in the community and who the patient is when they're in the hospital, as well as long-term care facilities, making that transition, making the transition to skilled nursing facilities and back into the community, back into the hospital, coordinating over time. So that's a little bit about what we do. What's unique about our team is that it's very flexible, that we can come up with creative solutions, whatever needs to be done in the situation in order to address that patient's needs. I've had a patient who kept ending up in the emergency room. He had severe COPD, kept ending up in the emergency room because he didn't really know how to manage his illness. And we actually helped address his issues by getting him a gym membership. And this helped him feel less lonely, helped his health situation, and then he wasn't ending up in the emergency room. So you never know what you might be able to do to help somebody. Another thing that makes our team unique is that the various team members are able to work side by side, whether it's the doctor, the psychiatrist, the social worker, the nurse, the community resource specialist. We're able to work side by side and respect that the other person has tools that that person doesn't have. It allows the doctor to be the doctor. So they're not sitting there trying to deal with the patient's housing issues or their family-related stressors because their child has a substance abuse problem. Whatever it happens to be, we're able to show that value and earn our seat at the table, as Angelo was saying, by showing what we can do to help patients and then allow the other providers to focus on what they need to focus on to improve the health outcomes for those patients. Another thing that makes our program unique is that it is evolving, and that it's evolving in a way that allows all of us to contribute to the creation of the program. So this ties into where the clinical and the macro meet. So we're not only doing the clinical work, we're also thinking about what this program should look like, what it should look like if it expands to other places, which it has done. We've expanded throughout partners. We've done training of new staff there, efforts to look at how it could be replicated there. I'm on a committee that's working on looking at what the ideal ratio between patient and care manager, patient and social worker. What are the factors that influence that? The acuity of the patients, the mental health needs of the patients, geography, whatever it is that feeds into that. What would an ideal program look like in terms of numbers? Also looking at what tools we need in our electronic medical record and how we can best do referrals, assessments using the tools that we have in order to work with the patients in the best way that we can. We also look at gaps in care. We have worked to develop a program that looks at patients during that time between the hospital and the skilled nursing facility and then the skilled nursing facility and home. So we have members of our team that track patients while they're there. We attend team meetings while patients are at skilled nursing facilities before they're discharged in order to help kind of grease those wheels and avoid patients ending up back in the hospital after that. Another recent effort, which we've just started to look at, is the idea of those patients that their primary needs are psychosocial, and they're not really best met by having a nurse care manager as their main point of contact. And in some cases, that may be detrimental to the patient. You know, someone who may have a personality disorder is doing a lot of splitting, and having a nurse care manager and a social worker and all of these people, they could just be using them in any way they possibly could. So in those cases, we've talked about coming up with a protocol where the social worker could be the lead person in that case, and then delegate out to the care manager when there are medical issues. So that's just one thing that we're looking at. So that's basically what we do. And I just wanted to add a little bit about how I got here and the skills that I think help in this type of healthcare environment. Before I came here, I had a position in the community. So I worked with an elder service agency. And then while I was here, I did an internship at Beth Israel, having more of the acute side experience, some outpatient work and some inpatient work there. And then both of these experiences led me to see that you really can't look at the patient in either one of these settings alone. And that's what's unique about this program, is that we're able to address the whole person across the continuum. And I think that holistic approach is what needs to happen, especially for these patients at the top, that 5% that are using the majority of the resources. Also, the simple fact of patient engagement, meeting the patient where he or she is at, and especially those patients that are refractory to the idea of social work and that need some time and need you to talk to them on a dumbed down level, and to just engage with them and get to know them and figure out where they're coming from, and not use a lot of theory or talk over them, etc. And then the whole idea of self-determination, which is something that we have struggled with in our program, especially working with the medical model, and that's been a major challenge for us. Many of our physicians and our nurse care managers coming from that background look at our patients as, well, they look at themselves as fixers, and it's hard to acknowledge that some patients and some problems can't be fixed, and it's more about working with them in order to try and basically a harm reduction model, which has been a big issue for our program and something that we've worked a lot on, and that the social work voice can add a lot of value there. So I will turn it over to Scott, who will talk more about it.
First, I want to thank Angelo for outing me as a Canadian and actually offer an apology. I'm going to apologize on behalf of the nation of Canada for the polar vortex, which is about to hit again. I will not apologize for Justin Bieber. I think he's his own person. So I'm going to start the presentation by just giving you an overview of where I come from, the organization that I work with. I am with Gosnold on Cape Cod. And some of you may be aware of the organization. We're primarily substance abuse / mental health organization, and our population is the population of Cape Cod. And if you think that's a small population, that there's not much going on during the winter, you're wrong. These are all our locations. On the left, you will see our inpatient facilities and our residential facilities. On the right, you'll see our locations for our outpatient facilities. So here's a little bit of data in regards to usage of services. The top graph on the left is our graph that shows the family-oriented services that were provided within I believe it's 2008 forward. And you can see that graph goes up. All of the graphs goes up because the service provision, we're constantly expanding our services, partly because of assessed need, but I think a piece of this is actually following with what we're talking about today, the expansion of healthcare in Massachusetts. The expansion of the number of people who can access healthcare directly affects hospitals and community organizations. So we are charged with finding ways to keep access open and have enough services or availability of providers so that the increased demand can be met, and that is a challenging thing. Okay, so I'm going to talk a little bit about our continuum of care, and this is going to start with where we are at as a traditional service. So I'll go through those rather quickly just to review them. Okay, so primarily Gosnold is known as a place that someone can go to spend an inpatient stay for alcohol and substance, other drug detoxification. And it's a short-term brief service. We also have a longer-term service for inpatient services. It's our program called the Katama program, and it's a 30-day program. This is a service that is actually quite a unique service in the state in the sense that there are a number of pieces to this service. One is the medically based detox, but other services such as the traditional counseling, family counseling, recovery coaching, which I will cover a little bit more later. We offer holistic type services here as well. If you could get anything from groups that are talking about meditation and yoga to more traditional CBT type services. We have extended inpatient stays at two of our facilities, one for men, one for women, and those are treatment-based programs. And our sober living environments are not so treatment-based, but they're structured programs, so people who have come out of a treatment setting can be actually living in a setting that's very supportive to maintain their gains with their substance use. Our individual and family counseling, this is where you would find more of the traditional services in our outpatient settings. So you would have individual services, family services, outpatient groups as well, which will be the next little piece coming up here. That is supplemented by psychiatry services as well. So we have a little bit of a wraparound with the medication-based treatment and also the traditional individual and family and group counseling. And our family support services, which I already mentioned, as many of you know, if you're focusing on somebody who's managing an addiction, it's not only that person who has the addiction, it's the entire family that is supporting the individual that is managing the addiction too. So we as an organization thought it'd be a very good idea to actually allow or provide services for families, educational and support services, so you could have the very basic, come in, you're stressed out, you're depressed, and because of what's going on, we'll help you out, to the more educational focused groups that we run. And those groups actually are very, very large groups. We were surprised at first how large they were, but they're very large groups. They're very well attended. There's a lot of need in the community for just education around how do you support somebody with substance use. So those groups have become very, very popular. So the new services, this is going to really dovetail very nicely with what we're talking about today, because as an organization, we realized in this healthcare environment, the changes with healthcare, we had to keep pace with what was going on and start to offer services that made sense, not only financial sense for us, because a lot of the services and a lot of the movement in the healthcare, the government focuses with healthcare, there's money attached to that stuff. So financially, we do well by providing those services, but we also realize that those services are actually incredibly effective for the folks coming in, and I'll just review those very quickly. Recovery coaching is an essential, we found to be an essential service for us. Recovery coaching is a new area, a completely new area actually in substance use, and what you do with this service is you have trained people who are in other aspects we'd call peer facilitators, peer support workers, that sort of thing. In substance use, we call them recovery coaches. They're trained folks to spend a lot of time with the people who are in treatment or completing treatment to sort of move to that next stage in their life of being in the community in a very supported way. So a recovery coach might typically take somebody to an appointment, help them with their medications, help somebody organize their schedule, organize them getting to recovery meetings if they need to do that. We've had recovery coaches who have flown on a plane with somebody out to Arizona to get into another program. It's a really incredible service. You may hear it from like the Hollywood perspective, where somebody's a coach being with somebody 24 hours a day. It's very similar to the type of service that we're also providing with this. Mobile recovery supports, this is actually where technology comes into play. We're with the University of Wisconsin, I believe, as a demonstration project for apps on people's smartphones. And these apps are actually created with somebody in mind who is in treatment but needs that extra little support with technology. So somebody may, on their cell phone, fill out a little daily rating scale on how well they're doing with the recovery. Are they feeling triggered for using some substances? And if they score a certain way, they may get a message back saying, give me a call. They're a support person, or you're doing great, and they may be motivational messages. It's a built-in technology support, which is really effective for people, particularly young people nowadays that are carrying their smartphones everywhere and live by their smartphones. So it's a really effective app, and it's very much a cutting-edge service. I think you're going to be able to see this more often with more organizations, but we actually got into the ground floor and are a testing project for this. Medication-assisted treatment, this is a push for healthcare changes as well, that as we provide treatment, we recognize that medications can be very, very effective in supporting folks, both a mental health perspective, but particularly with a substance abuse perspective. As you know, in our state, in many states across the country, there is a significant problem with opiate addiction, particularly among young people, very young, 20s and 30s and 40s, particularly is the age range that we often deal with. We find that there are very, very effective medications to support somebody in maintaining recovery. I'll talk a little bit more about that. And we've actually developed clinics, a specific clinic at one of our sites that is very focused on medically assisted treatment. It has a whole medical team attached to that, which includes a clinical social worker. Our outpatient detoxification program, this is pretty new for our state as well, that we provide services particularly to opiate-addicted individuals to get their services on an outpatient basis for detoxification as opposed to going to inpatient. They have to meet certain criteria to be able to be in this program, but again, it's a medical team and a clinical social worker and a recovery coach that is support people within that team. And it, again, it's a cutting-edge type of program for this state. Primary care integration services, very much what we're talking about today. This is about us as an organization moving out of our offices. As social workers, we have a lot of comfort in going into our office, sitting down, and waiting for the next person to come in. Times are changing with that piece. So, as an organization, we are now going out into other organizations and providing services on site. And one of our methods of doing that is through primary care offices and through federally qualified health centers. And I'll talk a little bit more about this one as well. But it's shaking things up because the way you do your social work, the way you do your clinical social work is incredibly different if you're sitting in a primary care office than if you're sitting in your behavioral health office in a community mental health center. Okay, so the medical assistant treatment program started 2011. We use oral naltrexone and Vivitrol for treating opiate-addicted patients. And if you get a chance to read about that, Google it, you will find a lot of research. It's very, very effective. Okay, and again, I just reiterate the staffing in that regard. The social worker on this staff is incredibly important because, as all of the panelists have talked about, the social worker brings the holistic perspective to the team. So our medical staff are looking at the medications and their side effects. Our recovery coaching is supporting them with the day-to-day activities. Our social worker is the one responsible for doing the assessment, the total functioning of the individual. And that is an assessment that is unique to social workers. None of the other professions have this holistic approach around when they're assessing this current problem going on. Is it about the system they're in? Is it about the family situation? Is it about the social circumstances in which they were brought up in? Is it about their culture? Is it about the physical stuff that's going on? We do that. As social workers, we look at all of that piece, and that's why the social worker has to be an essential part of that team. The social worker in these types of team environments provides brief social work or behavioral health consults. This may feel a little bit different for those of you who have been involved in traditional clinical social work, that it is a brief solution-focused approach. Our organization has underwent considerable training on brief solution-focused model, actually provided by somebody who's connected with Boston College, who did an amazing job at showing us that there's another way of doing this that we didn't realize was as effective as it was. So we're involved in that initiative. And it is not about spending a lot of time with people. It is about spending an effective time with people. So short-term can be as effective as long-term. Just for folks out there, I know some private practitioners might wonder about that a little bit, but if you do the right assessment and you use the right criteria, it can be a very effective model of supporting folks. And this I'll just really scroll through really quickly. This is, again, the outpatient detox program that I talked about. Now, both the medically assisted treatment program and the outpatient detox program are an example of integrated services bringing medical services on site in a behavioral health setting. This gets to the matter of what we've been talking about today, and it also helps support people in a holistic way. Our outpatient detox and our medically assisted treatment program are located in a clinic environment within our behavioral health clinic. It looks very much like a primary care medical office. And that's a really important point, because that's the direction we're heading in with a lot of our healthcare services now, is an integration of both the behavioral healthcare and the primary healthcare in one setting, one-stop shopping. The federal government calls that patient-centered medical home. You've heard that term here already. So it's actually bidirectional in the sense that behavioral health services are looking to integrate medical services right into their services, but we're also looking to integrate ourselves into the medical settings. So the two, and that's the theme that we should be thinking about as social workers, is how good am I at moving from one type of setting into another setting, and how flexible am I at moving through a medical-based team as well as a behavioral health team. Okay, and then this is just what I was talking about, so integrating into the primary care medical settings in the federally qualified health centers. My work as a social worker in one of our federally qualified health centers is to provide 20-minute sessions to folks for the whole day. Think about that for a second. That's a lot of folks coming through in a very rapid fashion, but that is the model for primary care. And as a social worker, it was a little bit of a learning curve for me, and that would be the challenge for you folks too as you move into this healthcare environment and getting jobs, that you need to be flexible to be able to provide that type of service as well as a more traditional longer-term service. And I'll go through some of the core competencies of social workers that have just come out that will be helpful in this regard. No more snow. As I said, sorry for the polar vortex. But what I would like to say, just in talking about my background as a social worker coming into this type of work, it was my MSW degree that actually allowed me to move here to the States, which is a really interesting story. The MSW degree is oftentimes when you're doing an immigration or emigration type movement to work in another country, the MSW degree becomes a very powerful degree for you, and not a lot of people know this. The federal government here had it listed as one of the degrees that was necessary for me to move into this type of work in this country. So somebody else getting another type of degree, I won't mention the other types of licenses that are similar, do not have that advantage that we have as far as working in other countries. So I just wanted to put that out, number one. The other aspect of this degree that was really helpful to me is it allowed me to sort of move through different health systems and behavioral health systems from one country to another, see the differences, but also to use my social work skills to be able to sort of understand the teams that I was moving into and effectively integrate into those teams. So that was just a basic gift to me from my graduate program in Canada to be able to do that. I am in a management position. I'm also in a position where I am helping the organization develop an EMR, an electronic medical record. You've heard about the electronic medical record. It is a tough thing to integrate into an organization, but it's the way it's all going. So I would give you the advice of understanding that Your clinical work, if you're going into clinical work or if you're going into macro work, is all going to be involving technology. The clinical aspect of it, you've already experienced in your own primary care offices where somebody's sitting there with a laptop asking you questions, typing in the answers. It will be exactly the same in behavioral healthcare in the next couple of years. And it's actually already started happening that way. So our challenge as social workers is how do we integrate that into a clinical practice in an effective way, respecting the person that's sitting next to you as you're doing that. So I'll leave that to you as well. So very quickly, last week, the SAMHSA, the Substance Abuse Mental Health Services Administration, put out core competencies for working in integrative efforts in this country. And I'll just list them real quick for reference. You can go to their website to look at them as well. Interpersonal communication, collaboration and teamwork, screening and assessment, care planning and care coordination, the ability to give an intervention, having cultural competency, being systems-oriented, adopting a practice-based learning perspective, and using technology. Those are going to be the 9 pieces that are going to guide you in your work in this field in the next number of years. So that is my presentation. Thank you.
Carol, thank you for just underscoring the importance of social work values and resiliency, hope, the strength-based approach, the issue of making sure that we don't serve all folks the same and your integrated case practice model, and the importance of kind of knowing where we're headed with your measures. You know, looking at the pharmacy, hospitalizations, quality of life. You know, we want to make sure good health care, but impact quality of life and the consumer satisfaction. So thank you for that. Mary, thank you for that visual. That's like, you know, the before and after. You know, the table of medications. Thank you for that. And thank you for that funnel of health. And thank you for that notion that there's a thing called clinical social work specialty. When we think about medicine, you know, one of the specialties is social work. And thank you for that visual on the triple aim. There are those triple aims. We're wanting to impact cost, satisfaction, and health. And the importance of the medical assessment and how that's one of the things we bring different. You know, there's the medical assessment that the medical team is looking at, and then there's the psychosocial assessment that the social workers are bringing. And Rebecca, you know, thank you for emphasizing engagement. You know, and really, when you think about engagement, there's an issue of persistence, the issue of trust, and sometimes we don't have that. And then this issue of flexibility of how we engage with people, with the folks we're working with, and this issue of how the programs evolve and how there's an opportunity to integrate the micro and the macro, which is a beautiful thing because the program design is actually getting based on the actual experience, the real life experience of providing the program and the services. And I really was impressed with your notion of that struggle of being the self-determination, because we're sort of embedded in a medical model, and how do we help our teammates do that struggle where we actually can get to notions of harm reduction. And Scott, thank you for this really emphasizing the need for new services, and that we are going to have to be looking at how to evolve the services we provide to fit the new model. Your notion of the electronic record and the use of technology, and we're going to get more and more comfortable with technology, and technology is going to be a tool that's going to actually help and enhance the work we do, particularly around helping us better monitor, and intervene on a day-to-day basis. I like what you're talking about in terms of that MSW and how portable it makes you as a professional. And that's one of the things I'm seeing as I travel the country, whether it's getting into a country or whatever. It's interesting. I Googled social work in Korea, and I went to their webpage and saw what, and a lot of what they have there are things that we've developed here in this country. I'm going to kind of pause there and open it up for questions, and hopefully you guys we've got about another 15 minutes, so you guys can ask the panel questions. Carol Trust.
You guys are so impressive, and it's clear that social work is the perfect perspective to work in the whole integrated healthcare project. More than a project, it's a movement, it's tidal wave. You're doing the direct work with the patients, the clients, the community. NASW's job is to support you in what you do. I have a dual question. One is, what can you do about moving the image of social work from that pathetic group of people who take kids away when they shouldn't take them, or don't take them when they should take them, to image question? And the other question is, help us come up with how we can increase the reimbursement rate and salaries for social workers. Those are the two most asked questions of our members. The issue of image and the issue of reimbursement and compensation.
I'll jump in, and I think one of Mary's slides when she talked about the where's my note? I made a really good note on that. On the return on investment, when you looked at for every dollar spent, there was $2.26, $2.55. Okay, so and that's one of the things we need to get better at as a profession is really getting very comfortable with the data, being able to document. There's input, and then there's output, and actually be able to say make that economic argument that we actually bring value. It's interesting when the docs and the hospital administrators talk about the value we bring, they relate it back to the DRGs. And about if they didn't have social workers, their DRGs wouldn't be where they want them. So as we get better articulating that value, be able to say, here's what we're bringing, and that's worth X amount as a profession. And then one of the things that NASW was critical in help filing at a national level was something called the Social Work Reinvestment Act. And there's not many sponsors for that. And within that, there's a look at salaries and compensation.
I could make a quick comment too. So I think from the perception perspective, I found that, each organization out there has got to have a champion of someone who embraces and is part of the leadership of the organization. And I think that can really help as social workers graduate from social work schools and move into management and leadership positions, and then become the champion of, trying to address that perception issue. So I feel like, while there's more and more of us having these conversations and, cross-fertilizing ideas and becoming leaders in organizations to help, fight that type of perception that you were talking about.
I'd also add that it's kind of up to us too when it comes to the salary piece to advocate for ourselves within our own organizations. I think sometimes as social workers we may say, well, and I'm not going to ask for a raise because this or that, or I'm not going to really push because I'd rather the money go to this or that, the other thing. And it is really important, I think, for us to be our own self-advocates in regards to pay scales and wages and that type of thing, because it really is, as we are feeling confident and strong within our organizations, part of that is that we're feeling taken care of financially. So I think that's partly up to us too to do that. I would just say that's a piece of it. It's not the whole piece, but that's a piece of it.
Hi, thanks so much for your wisdom and your examples today. My name is Tiziana Deering. I'm a professor here, and I work in the macro curriculum. I thought I was going to ask you about skill sets, but you did such a fantastic job outlining for our students the kinds of skills they might need. So I know that we have a lot of students in the room, and I know especially on the macro side, one of the things that is on their minds is jobs. And I hear in your portability comments, your skill set comments, there's a new frontier of employment out there. And what are some of the jobs in this new frontier that our students can be thinking about that are the ones they can aspire to, the ones they can be going for, the ones they can turning themselves towards as we reform healthcare.
Well, I think Charlie Baker alluded to this around healthcare navigation. I mean, I feel like to the extent that in schools of social work, learning the various medical and behavioral health terminology, the various types of health plans, how they're funded, how to access them. And, you know, social workers are so great at advocacy. I think that that's really one way to address that issue.
From a macro perspective, I would say there's a lot of opportunity out there. What I find in healthcare is there are a lot of folks that know a lot about medicine. They don't know so much about planning and program development. And I think the experience, the skill set for those in macro is being able to take an idea and grow it. And so think about those skills that are really important while you're in your placements and honing in on skills like facilitation, presentation, slide decks. We live and die by slide decks. I'm so sorry to say, but we do. But learning to talk without slide decks as well, and being able to facilitate, being able to take this idea and that idea and bring it together and come to a good outcome, to move an agenda forward, to take an idea, to create a project plan, to be able to put a timeline to it, and to get buy-in for it, build a budget, write a job description. When you're in your field placements, push to get concrete skills like that. Very concrete skills. It's really, really important. Important to take it away and be able to talk the language when you then start interviewing. I spend time writing job descriptions. I spend a lot of time with budgets. I look at data every single day. I graph it, I chart it, I track it. It's you know, I always say it's 50% of our conversation. We start with data, and then we ask our team, folks like Rebecca, what is it telling us? What do we know from this data? Is it right? Is it on track? Being able to facilitate our program developed because our team had great ideas. My job was to take those ideas and make them happen. My job was to be able to see, you know, where we were going and keep us on track. So think about that as you're in your placement and what you can take away. I always think in placement you should have a portfolio. At the end of the day, you should have a portfolio of experience that you can then speak to in job interviews. Think about informational interviewing. Think about people who have graduated from this program in years past. Sit down with them. Don't be shy. Social workers have to stop being shy. Have to absolutely stop being shy. You have to, as I say all the time, you have to own your place at the table. You have to be able to, you know, to sit up and feel confident in what you know and what you feel and what you believe. Be passionate about the work you're doing. And so reach out to people who graduated last year. Ask them what their job search has been like. Reach out to people who graduated 5 years ago. Reach out to people who graduated 28 years ago, 29 years ago, and, you know, and ask and tell them the things that you're interested in doing. And ask them.
Yeah, I think Charlie Baker said it well when he said, find an organization that has a culture that matches your values. I mean, maybe it's not the exact right position that you were hoping for, but if you can join an organization that you feel has the right culture and the right values, you're going to grow and flourish. And I think that's another important message. Be flexible when you're out there looking, and join an organization that has a culture that really resonates with you.
And there are actually going to be plenty of jobs for social workers. The Department of Labor predicts by 2022 we're going to have a shortage of social workers. You know, currently we have about, Labor Department estimates about 700,000 social workers. About 400,000 of those social workers are licensed. 25% of those social workers work in the medical field. And as there's more emphasis, and that's part of what today's about, is there more emphasis on health reform, there's going to be more need for social workers. So there's going to be more need for social workers in medical social work. There's going to be more need for social workers in military social work. Unfortunately, the new normal we live in, the deployments are longer and longer. veterans and their families have more issues they're addressing. There's going to be jobs for social workers and child welfare. Many states are professionalizing their child welfare workforces and putting in preferences or legislation that requires BSW, MSW for social workers, masters for supervisors. There's going to be work in corrections of forensic social work, school social workers. And actually, when you think about our social work workforce, 30% of the social work workforce is over the age of 55. When you look at all other professions, 14% of the workforce is over 55. So actually, I've been encouraging people we're going to have to start talking to 7th graders, getting them interested in social work. So by the year, in 10 years, those 7th graders will have MSWs. I had the experience of doing the commencement address here in 2008, and one of the people in the audience was in the 7th grade with my daughter. And it doesn't take long to get from the 7th grade to an MSW, unfortunately.
If I could
I'd just like to add geriatrics. It's one that you forgot. It's one that I'm in, and it's one that I love. When I graduated from the School of Social Work, there wasn't a geriatrics program. Now there is. But I didn't have that, and I didn't know it was a passion until I found it. So I will, and I also have a daughter in her first year of social work school. So got to breed them too. But Mike, and I mean, everything you said is so poignant because I actually am an LICSW. I did not look at macro. I didn't know how to write a budget. I didn't know how to do any of that. I started in home care as a social worker after my focus on adolescents changed when I had children. And I fell in love with geriatrics by accident. I started a private care management company and had no idea how to do that or what business meant or any of those things, but I did it because I felt a need and a passion. I've since then, now I'm the vice president of care management for a nonprofit who purchased my company in 2009. So there's ways to do anything that feels passionate. I will tell you for sure, and I'm looking for lots of social workers. So, but I will say that the question I came to ask today was to the two on the end. I have two of them. The Partners Program, I work with MGH and all of you often, and you do a great job. But I know that I struggle with the medical model. I am in a nonprofit company that has home care, and our care management services, they are private pay, number one, although I've been given money to do free service, which is fabulous, and one of the reasons I went with this group. My question is, when you're working with these folks that come in with these chronic illnesses and you're following them, are they coming to you only because they're in the medical system? I think I know the answer. And how do we encourage, I would have asked this of Charlie Baker, for some of this proactive work prior to them coming into the medical model? So that's my question for MGH. I'm going to ask them both so then I can sit down. My second question on the substance abuse is, fabulous, great service needed there, but what we struggle with is substance abuse for the geriatric population. Very, very different, very hard to come by, so many different areas of issue. So how do you handle that if you do, and what are your thoughts if you're not currently, that we can expand that? Thank you.
So to answer your question about basically how you become involved in our program, it's a primary care-based model. So we work with the primary care offices at MGH. It has expanded throughout Partners. And our patients are selected based on their risk score, and Mary could tell you more about how that is determined. So they're considered to be high risk. We work with Medicare patients now, commercial patients, and we also have some mass health patients through NHP that are just coming into our system. So any patients that are in those categories and are deemed to be high risk, they come on a list that is given to our care manager. They review them with their PCP, determine who is appropriate for the program, and we go from there. There is a process for opting in, but it's all tied to the primary care doctor.
In answer to the geriatric question, we as an organization followed a very similar model to what we're doing with the primary care initiative integration. We actually have gone out into the community. We have a few geriatric outreach workers that are actually out in the community working with the geriatric population, and we are actually integrating a lot of our workers into the senior centers on the Cape. so that we're actually housed at the senior centers a couple of days a week to provide services. Now, those are general services for the folks in the town that senior center is located, but also what we do is we form connections with the directors of those facilities, and we get referrals directly from them for the senior population. So that's what we've been doing in regards to that piece. I just need to throw this in really quickly because my outreach director is sitting there is going to get very angry if I don't say that we are also looking for social workers. so if you're considering work on the K, see either of us afterwards.
Would you guys join me in thanking the panel for...
Thank you, Angelo. Thank you. A wonderful group of social workers. And Mary, just to make you feel a little bit better, some of us have been practicing since 1978. So you're youngin' for my book. Just in a few closing remarks. First of all, really just want to thank you so much for your wisdom, your experience, and your commitment to what you do. And truly your willingness to be nimble. All of us are engaged, this group up here in Angelo, in social work practice very different than probably what we thought we were entering when we were entering the field for some of us, many years ago. But at the simplest level, integrated behavioral and physical health care occurs when behavioral health specialty and primary care providers work together to address the full health needs. You heard that a lot today, the holistic needs of their patients. And as you heard today, hopefully, integration can and should be bi-directional. It really should be based upon the patient and the patient experience. And if that's a new term for some people, by bi-directional, what I mean by that is either the specialty behavioral health is introduced into primary care settings, or primary health care is introduced into addictions or mental health settings to truly meet the holistic needs of the patients. If I put on my former hat as a commissioner of mental health, which I sort of have to on occasion, both Massachusetts and the ACA have very strong protections for behavioral health insurance coverage. And I want to stress that's coverage, not necessarily the availability of services. The ACA requires that behavioral health be included as an essential benefit offered by all private insurers. All state Medicaid programs are required to provide behavioral health coverage. Whether they expand their state coverage or not, they have to include behavioral health. And commencing this year in 2014, the ACA enhances the quality of insurance coverage by extending the reach of the Wellstone-Domenici Act of 2008, and for those who do not know what that means, that's the federal parity law, across all commercial plans, both ERISA and non-ERISA plans. That is a huge marker, huge change for all insurance plans in the Commonwealth of Massachusetts and across our country. Healthcare reform emphasizes integrated models of care, and you've heard some examples here today. Translating that into our academic social work training and profession, there will be significant demand for healthcare social workers trained in evidence-based interventions, care coordination, integrated team-based care, and health promotion education. Care coordination is required for the ACA success. Implementation of the triple aims is well matched to social work values and ethics. As you've heard, there's a significant shift towards ambulatory and home and community-based health care. Long rooted in our values, social work must ensure that our skills are relevant in this rapidly changing healthcare landscape. Social work is at the healthcare table because you know what? It's not one table. Every social worker who's spoken today is at a healthcare table. It's an exciting time, one of healthcare challenges and opportunities. For many, the ACA, and for me, is the civil rights legislation of this young century. We must ensure that social workers, from policy to practice, are front and center in this success. After all, healthcare should be a right and not a privilege. I want to thank Dean Gadenzi for encouraging this forum and for embracing this issue. This is only the beginning of this conversation within our school and our community. As a final note, please remember to hand in your CEU evaluations or you will not get your certificates. I had to say that. And they will also help guide our future planning. And we hope that you will all stay for reception in honor of Angelo in his new role as President and CEO of NASW. That concludes our formal presentation for today. Thank you so very, very much.